Okay, hopefully everyone can hear us. Welcome back. Welcome back to, again, the virtual APA 2020. The session is Perspectives on Outcomes in Pancreatitis. It's my pleasure to co-moderate together with Professor Pramod Garg. I'm Aida Habtezyan. Our first session is going to be by Dr. Vijay Singh. He is a professor at the Division of Gastroenterology and Hepatology, as well as Department of Biochemistry and Molecular Biology at Mayo Clinic in Arizona. His primary research interest includes clinical gastroenterology and research in pancreatic disorders with specific focus on pathophysiology of acute and chronic pancreatitis. He has particular interest in mechanisms regulating the function of pancreatic acinar cell, including vesicular trafficking, cytoskeletal regulation, intracellular signal transduction. In addition, Dr. Singh is investigating how obesity-related pancreatic fat worsens local injury via unsaturated fatty acids. His research team is also developing techniques known as transgastric local pancreatic hypothermia, which is a novel, rapid multimodal therapy for acute pancreatitis. With that, I'd like to welcome Vijay Singh, and his talk is entitled Role of Lipases in Organ Failure and AP Outcomes. Thank you, Vijay.
Hello, everybody. I hope we APA members are all staying safe, healthy, and happy. I would like to thank the organizing committee for this opportunity to present our thoughts on the role of lipases in organ failure during acute pancreatitis. Unlike the classic models of pancreatitis severity, which claim that severity is related to etiologies such as cerulean or bile salts, here I hope to convince you that severity of pancreatitis is due to the lipases that are released which worsen pancreatitis. We will also briefly touch on the relevance of this pathophysiology to COVID-19. This is my disclosure. I believe that dietary fat and therefore visceral fat composition impacts not only pancreatitis outcomes, but also those of COVID-19. The relationship of fat and obesity to severity of pancreatitis predates that of the widely claimed role of trypsin proposed by Chiari in the late 1800s. As seen in yellow, Dr. Fitz in 1889 concluded in the medical monographs that an excessive growth of the fat cells near the pancreas occurs in many men. It may become so excessive in very fat people that a large part of the abdominal fat dies, and it thus proves fatal, either on account of the quantity destroyed or the associated hemorrhage. In fact, in the green shade, he mentions that Chiari had also found fat necrosis associated with pancreatic diseases. And mind you, this predates the findings that are published about trypsin. And although Chiari, in his published report, he made no note of the characteristic appearances of this fat necrosis. He knew these before he talked about trypsin. Even in the modern day, this necrotic fat is our main target, as you can see here. Whatever intervention we do, whether it's an endoscopic or percutaneous or surgical, it's this fat that we are usually debriding or removing or draining at the time of working on pancreatic necrosis to improve outcomes. To understand the role of this inflamed fat a little better, we compared pancreatitis to diverticulitis, since both are called out by radiologists based on the fat stranding that surrounds the organ. However, organ failure in diverticulitis is much rare. It's about 2.9%, versus in infected necrosis, organ failure in sepsis can be as high as 25%. In diverticulitis, as you can see on the left side, there is fat stranding around the colon. On the right side, as we have commonly seen, is the progression of a peripancreatic collection in the fat surrounding the pancreatitis. And by day 22, this patient was septic, and on day 24 required drainage of that fluid because she was in the ICU, in respiratory failure and renal failure. This table here compares the diverticulitis patients who required a sigmoid resection to pancreatitis, as we see here, who required a drainage of the fluid collection. And as you can see, the prevalence of organ failure was statistically higher in the pancreatitis group. When we analyzed the chemical composition of this pancreatitis, we found that it was very high in amylase and lipase activity in the peripancreatic fat versus the ones in diverticulitis had much lower activity. And when we chemically looked at the composition of the fat, that of diverticulitis was predominantly triglyceride, while the fat necrosis in acute pancreatitis, the triglyceride had been degraded to non-esterified fatty acids, as you can see here on the left side of the two standards for triglycerides and non-esterified fatty acids. We have previously published on the composition of necrotic collections shown here as NCs, and you can see that necrotic collections are enriched in unsaturated fatty acids. And the main ones among these are oleic acid or C18-1 and linoleic acid or C18-2. We then studied the effect of directly introducing pancreatic lipase by injecting it into the fat or visceral fat of mice, which are obese. In A, you can see that after an injection of pancreatic lipase, survival of mice gradually came down, whereas this was prevented when we co-administered orlistat or ORLI, which is a lipase inhibitor along with the lipase. In B, we can see the gross appearance of the fat necrosis, showing this cheesy white deposits in the fat, which was completely prevented by orlistat. Consistent with the injection of lipase, there's a large increase in lipase activity in the fat pads, and we noted that there was degradation of the triglyceride in the fat pads of mice which had been given the lipase injection to non-esterified fatty acids, where this was prevented by orlistat. Consistent with what we noted in human pancreatic collections, there was an increase in C18-1 and C18-2 in the lipase injected group, which was prevented by orlistat. Not only that, interleukin-6, MCP-1, and TNF-alpha were dramatically increased in the groups which had gotten the lipase injection into the fat pads, and this was completely prevented by orlistat. Again, cytokine storm, which was triggered by the lipase injection, prevented by lipase inhibition. Similarly, there was organ failure. Serum BUN was elevated. There was a drop in rectal temperature, consistent with hypothermia, which is in severe SIRS, and there was a decrease in pulse distension, consistent with shock in the lipase injected group. What we measure over here in pulse distension is carotid pulse distension in micrometers, and this again was normalized by orlistat. These findings are consistent with organ failure. So we can see that a lipase injection without pancreatitis into fat pads can cause the cytokine storm and organ failure by generating fatty acids, which are very similar to human pancreatic fluid collections. Here we can see that the cytokine storm can be triggered by just injecting oleic acid into mice. In the upper panel is the serum oleic acid levels in mice given oleic acid, which are very similar to serum oleic acid levels in severe acute pancreatitis patients who have sustained organ failure. Again, oleic acid can trigger the cytokine storm and cause organ failure, very similar to the lipase injection we noted in fat pads. The lung tunnels become positive, which is consistent with ARDS. So fatty acid alone, by administration into the peritoneal cavity, can trigger the cytokine storm and cause organ failure. We went on to study the role of the main pancreatic lipase, or PNLIP, in the severity of pancreatitis. For this, we had 3 strains of mice. We had obese mice, which were just OB-OB. obese mice, which are shown in black, and obese mice, which are ATGL knockouts or knockout for adipocyte triglyceride lipase, which is the main lipase in adipocytes. And in gray are shown the mice which were pancreatic triglyceride lipase knockouts or PNLIP knockouts. When we induced pancreatitis with cerulean in them, the induction of pancreatitis was essentially the same. The pancreatic edema was the same. The increase in plasma amylase was the same in all groups. So there was no difference in the initiation of pancreatitis. Lipase was less because these were lipase knockouts. However, what we note is that the cytokine storm and organ failure, that is, the outcomes of pancreatitis, were dramatically different. The PNLIP knockouts had near normalization of IL-6, TNF-alpha, and MCP-1, and pulse distension, rectal temperature, and survival were all improved in the PNLIP knockouts, but not in the ATGL knockouts, which are shown in blue. So based on this, we can say that whereas in diverticulitis, there is fat involvement and there's a microperforation, which causes leakage of bacteria into the peritoneal cavity, and there's a very strong, intense acute local inflammation. And I didn't show you the histologic pictures, but organ failure is rare. Whereas in pancreatitis, with the leakage of PNLIP from the acinar cells basolaterally, the hydrolysis of the native triglyceride of adipocytes generates a lot of NEFA, which cause organ failure, including ARDS, renal failure, and shock by entering the systemic circulation. Along with this, they cause a cytokine response, like the cytokine storm. So is there a relevance of this lipolysis and lipotoxicity beyond acute pancreatitis? And let's see what this could be happening in COVID-19. Acute pancreatitis and COVID-19 share many similarities. Both are acute diseases. There is severity in both cases in about 10 to 30% of cases. Both are worsened by obesity. Both have multisystem organ failure when they're severe. Both have a cytokine storm, as we saw it. And additionally, there is two very other important things which are a part of pancreatitis severity criteria, Glasgow criteria and Ranson's criteria. Those are hypoalbuminemia and hypocalcemia that they share. And these are mechanistically important, as we'll see later. Interestingly, there are two autopsy studies which have come out in COVID-19. The full autopsies, if we take them together, show that 7 out of 18 patients had pancreatitis with fat necrosis in COVID-19, in severe COVID-19 infection when patients died from COVID-19. That amounts to about 30 to 40% of all cases. A study in JCI Insight showed that patients with COVID-19 with high interleukin-6 levels had elevated levels of unsaturated fatty acids. You can see C18-1 and C18-2 are significantly elevated, while C18-0 is also elevated, but you can see that the differences from baseline are the highest for the unsaturated fatty acids. And the reason this is important is, as we saw earlier, unsaturated fatty acids like oleic acid, which we saw earlier, and linoleic acid can trigger the same spectrum of disease as severe COVID-19. Lymphopenia, which is seen as tunnel positive cells in the spleen, can be triggered by unsaturated fat. Similarly, thrombocytopenia, hypoalbuminemia, liver injury, renal failure, the cytokine storm, which we saw earlier, hypocalcemia, severe SIRS, shock, and mortality are common between the lipotoxic injury we note with unsaturated fatty acids and severe COVID-19. And the reason this is important is because fatty acids and can be neutralized by albumin and calcium. Here we see the enthalpy of the reaction in red and green respectively. These bind the unsaturated fatty acids that are generated, but when there is too much unbound, these can lead to cell injury that we note over here. And this may have some relevance to the therapy of COVID-19, especially as we see in famotidine formulations, which over the counter, we see that the chewable famotidine, such as Pepcid Complete, has a lot of calcium carbonate in it. And studies have shown that outpatient subjects who were on famotidine had better outcomes in the inpatient setting when they continued their formulations. These are the 3 studies that showed improved outcomes in continuing famotidine in the inpatient setting. And this is the calcium carbonate enriched famotidine, which is very popular over the counter. So far, there has been 1 study done in inpatient settings in Hong Kong using famotidine alone, and there was no benefit. There's a clinical trial going on in famotidine, which was completed on the 7th of September. The results are still pending, and there's a planned trial on famotidine, which is going to take place in Iran. So based on these, we can say that excessive and unregulated lipolysis of visceral adipose tissue causes multisystem organ failure. Excessive lipolytically generated unsaturated fatty acids cause multisystem organ failure, sepsis, and death. And unsaturated fatty acids can be targeted to prevent COVID-19 from getting worse. I thank you all for your kind attention.
Thank you, Vijay. Can you unmute yourself, Vijay, so we can see you? And if there are any questions in the chat box, if you could please put questions, post questions there, and we'll try to unmute people to also ask directly Professor Singh. Vijay, if I may ask a question while we wait for some of the chats to come. Can you hear me, Vijay?
Yes, can you hear me?
Okay. Yeah, thank you again for the question. Actually, there's one question from Richard Waldron, and let me see, I'll read that and then we'll try to open the chat virtually so people can ask directly questions to you. Where does the calcium go? Redistribution to tissue, or I think, Richard, do you want to ask the question directly?
Sorry, I meant to imply crystal. Crystal is into crystalline form. I would worry that, you know, if we put calcium back in the blood, okay? I mean, it's involved in hemostasis, right? So there are coagulopathies in AP. I wonder if it would promote coagulation there. And I would also worry about its role in the tissues, because if there is indeed excessive calcium entry in acinar cells, that can be bad. So I would think that, I would wonder why it's beneficial to add back the calcium.
Very valid question. I will share my screen with you because there's some background needed to answer your question. So let me know if you can see my screen. Can you see it now? So
yes, Vijay.
Yeah. So the point is that when we have lipolysis, fat breakdown, generation of fatty acids, our normal serum calcium, which is around 10 milligrams per deciliter, goes down. We get hypocalcemic. So all we're saying is bring it back to normal. All that needs to be done is bring it back to normal. And in fact, this paper that I'm showing you over here is on the mechanisms of ringer lactate, that it's basically providing the extracellular calcium. Ringer lactate has 3 milligrams of extracellular calcium. We give it at a high flow rate, about 5 to 6 liters or more per day in acute pancreatitis. We are actually replacing calcium with ringer lactate, is what we are actually doing. And we are not saying that you bring it up to 13, 14, you bring it just back to normal, 9 to 10 or whatever the normal range is. So it's bringing it back to physiologic levels, because what happens during pancreatitis, and which the Glasgow criteria show and the Ranson's criteria show, and which we see just a fatty acid can trigger, is acute hypocalcemia.
Thank you, Vijay. There's a question from Sohail Hussain. Sohail, can you unmute yourself?
Oh, yes. Well, I think Vijay, hinted on the answer. My question was very similar, which was how does calcium improve lipotoxicity? I think you touched upon it, but can you elucidate upon the mechanism? It sounds like it's extracellular there's a sink here, but the biochemistry of improvement.
Sure. Again, I'll share my screen with you. So what you see here is isothermal titration calorimetry. What you see here is a reaction between calcium and a prototypical fatty acid that is generated during fat necrosis or visceral fat lipolysis, linoleic acid in LA. And just as a comparison, if you look at on the right side in panel C is just the other background reactions that can take place, and you see there's not much of a signal at all. But if you compare the magnitude of the reaction between calcium and LA, you see a huge exothermic reaction taking place. And that is the mechanism of how hypocalcemia sets in. And that is the mechanism by which extracellular calcium is going to prevent outcomes over here by the fatty acids that are generated by neutralizing them. So this is it's a ionic interaction. It's a fairly strong, the enthalpy of this is about minus 20 kilojoules per mole, which is fairly strong if you look at into the realm of other typical chemical reactions that take place, or protein-protein interactions, SH3-PRD interactions. This is substantially stronger than the typical reactions that take place in biological systems.
Thank you, Vijay. There is a discussion between Miklos and Marcus Lurch. I would let them discuss it. So Miklos, if you can talk about that, and then I would like to give an opportunity for Maria Sabatini to ask the question. So Miklos and Marcus.
I just made the comment that Chiari never talked about trypsin, and Marcus corrected me that Chiari knew about trypsin. Even though he never commented. But my more serious comment, it's so great to see Vijay with the beard. I've never seen that before. And this is because of COVID. We never see each other anymore. This is very good to see you, my friend. I'm done.
Oh, well, thank you. I hope you'll keep a beard too sometime, but that's okay.
Marcus?
Same as you for me. Excellent presentation, Vijay. I always considered, if there is any effect of lipase and the advent of necrosis, that to be a late event. And as Miklos and myself pointed out, the proteases are first and lipase comes probably later. You're challenging this hypothesis. So is there a way of testing it with Olistat in humans, or is that an approach one could choose or select? And how would it be applied interperitoneally? Or, well, the only real experience we have as Olistat is by eating it to inhibit lipase. Any prospect of getting this into clinical trials, Vijay?
Excellent questions. Thank you, Marcus. So I believe your first question, there are two parts to this, I believe. First is what comes first, and the relevance to that lipase is a later event and trypsin comes first. And the second part was relevance of lipase inhibition. Yeah, so talking about the first. So that was it was addressed in the beginning of the talk. Literally, what I typically say is initiation does not equal outcomes. That the initial events that take place in pancreatitis have nothing to do with outcomes, whether we take the initiator being biliary pancreatitis or alcoholic pancreatitis. It's fat, which is the modifier that changes the course of the disease. If you look at, now going back a little further, I do agree that with hereditary trypsinogen mutations, we can have very early onset pancreatitis. Yes, we can have recurrent acute pancreatitis, but if you really look at trypsin from a pure clinical standpoint, that clean model of PRSS1, the incidence of organ failure and mortality from PRSS1 mutations, I don't know of any cases. Maybe there's been one or two ever talked about, but it's a very rare event. So we can start a disease process with trypsin for sure. And trypsin can cause cell damage, but it's the fat around the pancreas and in around the pancreas that changes the course for worse. And then there are other evidences. The most common evidence I quote in this regards is when a patient comes to the hospital, the first thing that a radiologist calls is peripancreatic stranding. That's the term they use, peripancreatic stranding. And that's how they call pancreatitis. So stranding of what? It's the fat around the pancreas that is getting stranded. It's the leakage of stuff into the fat that is causing damage. And yes, if we go further to the time when early surgeries used to be done for pancreatitis on day 1, day 3, day 4, we can see there is documented literature that the first thing they saw was damage around the pancreas. Inner pancreatic damage of the parenchyma was much less than the high prevalence of peripancreatic damage that we witnessed. So yes, we have been taught, and yes, it does take place in PRSS1 that trypsin precedes lipase, but it doesn't determine outcomes. Second part about pharmacologic lipase inhibition. You're right, orlistat is taken by mouth, 97% comes out in the stool. What is absorbed has very weak metabolites, which have less than 1,000th activity of orlistat. Yes. So yes, that was my disclosure, that we are working on moving ahead a drug which is agent 767. You've probably heard about that before. It's in the early stages, and yes, we will hopefully try to move it ahead and see if we can bring it to clinical trials for pancreatitis.
Thank you, Vijay. Maria Sabatini, do you want to ask? We'll take that as the last question, and then Vijay, if you could please answer the chat box for the rest of the questions. Maria?
Yeah, I just wonder if you can apply the same concepts to the acute hepatitis or liver steatosis, or the bile have a protection role to eliminate fatty acid and then inhibit in some way the action of the lipases.
That's a great point you bring. So again, I'm not a liver guy, but if you look at the stages of liver disease in relation to this, we can have steatosis without steatohepatitis, right? So there can be a lot of fatty liver. So fatty liver per se is like, in the pancreatitis equivalent is like obesity, that you can have fatty liver there. But then the inflammation that happens is the pancreatitis equivalent. And the endpoints, if you really look at what we are dealing with in advanced liver disease, is organ failure. Whether we call it hepatorenal syndrome or HRS, or we call it acute kidney injury in pancreatitis, it is the same progression of disease that is taking place. If you look at what therapies we use in hepatorenal syndrome, it's albumin, am I right? We give octreotide, everything else, but what is that one thing? We have tested octreotide to other vasopressors or omitted, I've forgotten the name of the pressor we use over there, the sympathomimetic, but we have never omitted albumin from the treatment of hepatorenal syndrome. So yes, the end organ damage that is eventually occurring, organ failure that is eventually occurring, we put different labels, but it is essentially the same.
Thank you, Vijay. Thank you very much. Go ahead.
Thank you, Vijay. Excellent talk. Before I let you go and move to the next, can I just have one small question? I think it's very interesting what you show, that it depends on the unsaturated free fatty acids which incite organ dysfunction. My only point is that we really don't see that well a dose-response relationship, because there are so many people who are overweight, those who have visceral fat, but they don't develop that much of organ failure or dysfunction. So there is too much of heterogeneity when you look at the clinical outcomes of these patients. So your thoughts on that?
Excellent. It's not the amount, it's the composition that matters. And yes, we have talked on this many times about this heterogeneity, that the cutoff BMIs in the Western Hemisphere, for example, are 30 or even 35. That when we start seeing adverse outcomes, we go to the East and there you see cutoff BMIs of 23, 25 taking place. And then you look at the kind of diets we eat and the kind of visceral fat composition. These studies have been done since the 60s. They are very different visceral fat compositions we find. So the threshold BMIs that end up being required, or amount of visceral fat that we end up requiring, is much more if it is a substrate that cannot be hydrolyzed, a substrate that is less toxic, such as saturated fat. So I just say that the simplest thing is, if you think that unsaturated fatty acids are more explosive, one is like a stick of dynamite, let's say, if we say like saturated fat, yes, it'll cause a little explosion, but the other is like much more potent than that. A little can cause a lot of damage. So that's the cutoff BMI differences that we see between the reports from the Eastern Hemisphere versus the West.
Thank you. Thank you for an excellent talk, Vijay. With this, we move on to the next talk, which is going to be delivered by Atsushi Masamune, my good friend from Japan. Dr. Atsushi Masamune is a professor and chairman
of the Department of Gastroenterology at Tohoku University, Sendai. And he's going to talk about current status of acute pancreatitis in Japan. Because of the time constraints, he is not able to join us live. So we won't have questions after this talk, but you are welcome to post your questions on chat box, which we will duly pass on to him. So let's begin with the talk by Dr. Masamune.
Good afternoon, everyone. First of all, I'd like to express my special thanks to the organizing committee for the kind invitation to this virtual APA meeting 2020. I sincerely apologize for not attending the meeting on real time. It is 2 a.m. in the morning here in Sendai, Japan. Today, I will talk about the real-world clinical practice of acute pancreatitis in Japan based on the latest nationwide epidemiological survey. I have no COI to declare related to this presentation. Acute pancreatitis AP is an acute inflammatory disease of the pancreas. About 20% of the patients developed pancreatic necrosis and multiple organ failure, which may eventually be fatal with mortality rates historically as high as 30%. Up-to-date information in the real-world clinical practice is essential for better understanding and management of AP, as well as validation and revision of the clinical guidelines. In Japan, nationwide epidemiological surveys of AP have been conducted every 4 to 5 years under the leadership of these great professors, Professor Yoichi Saito, Professor Michio Ogawa, Professor Makoto Otsuki, and my mentor, Professor Toru Shimosegawa. To provide updates on clinical practice of AP in Japan, we, the Japan Pancreas Society, conducted a nationwide survey targeting cases in 2016. We surveyed AP patients who had visited hospitals across Japan in 2016. This study consisted of a two-stage survey. The number of AP patients was estimated by the first stage survey, and their clinical features were examined by the second stage survey. 34.1% department responded to the first survey. In the second stage survey, we obtained detailed clinical information in 2,994 AP patients. Now I will show you the result. The estimated number of AP patients in 2016 was 78,450, with an overall incidence rate of 62 per 100,000 persons. The estimated numbers of AP patients continued to be increased since the first survey. Compared to the 2011 survey, the number was increased by 24%. The male to female ratio was 2.0. The most affected ages were 60 to 69 years in males and 80 to 89 years in females. The mean age at disease onset was 59.9 years in males and 66.5 years in females. First symptoms. Majority of patients presented with abdominal pain, followed by vomiting. The slide shows the etiology. Alcohol was the leading cause in male patients, which accounted for 43% cases. In female patients, gallstone was the leading cause, which accounted for 38% cases. Alcohol was the leading cause in middle-aged patients, and gallstone was in elderly patients. In this survey, pancreatic tumor was the fourth leading cause, both in males and females, which accounted for about 3% cases. The slide shows a case of early pancreatic cancer diagnosed after recurrent episodes of AP. ERP reveals a slight stenosis of main pancreatic duct, but EUS reveals no pancreatic tumor. The patient underwent distal pancreatectomy, and post-operative histological examination revealed stage 0 early pancreatic cancer. The patient is alive for more than 7 years. We have to keep in mind that pancreatic cancer might be a cause of so-called idiopathic AP, especially in elderly patients. In Japan, the severity of AP is determined according to the Japanese severity criteria. The criteria independently adopt the prognostic factor scores and contrast-enhanced CT grade. The patient is classified as severe if the prognostic factor score was 3 or more, or the contrast-enhanced CT grade was 2 or more. Based on the Japanese severity criteria, 76.4% patients were classified as mild AP, and 23.6% patients were classified as severe AP. About 60% patients were classified as severe according to the CT grade only, 27% according to the prognostic factors only, and 13% patients according to both the prognostic factors and CT grade. Among the severe AP patients who fulfilled the CT grade only, nearly 90% cases presented score 2 in the progression of inflammation, that is, inflammation beyond lower pole of kidney, but score 0 in the hypo-enhanced region of the pancreas that is absent or limited up to one segment of the pancreas. Next treatment. Initial resuscitation within 24 hours after admission was about 3,300 ml in mild AP and about 4,000 Next treatment. Initial resuscitation within 24 hours after admission was about 3,300 ml in mild AP cases and 4,300 in severe cases. Next treatment. Initial resuscitation within 24 hours after admission was about 33. Next treatment. Initial resuscitation within 24 hours after admission was about 3,300 ml in mild AP cases and 4,300 ml in severe cases. The volume was significantly higher in severe AP cases than that in mild AP cases. The Japanese clinical guidelines for AP state that enteral nutrition should be started within at least 24 hours of admission because it can reduce the incidence of complication and can contribute to an increased rate of survival. The performance rate of enteral nutrition has been increasing since 2007, but still as low as 32% in severe AP cases. In the 2011 survey, only 5% cases received enteral nutrition within 48 hours, and 20% received between 48 hours and 1 week. In the 2016 survey, 90% received within 48 hours, and 60% received between 48 hours and 1 week. Thus, the starting time has clearly shifted to earlier. However, prophylactic antibiotics. The Japanese guidelines state that the prophylactic administration of antibiotics is not necessary in mild AP, but may improve the progress in severe AP and necrotizing pancreatitis. Prophylactic antibiotics were used in 95% mild and 99% severe AP cases. Both in mild and severe AP cases, carbapenem was used in about 40% cases, followed by cephem in 25% cases. In Japan, continuous regional arterial infusion (CRAI) of proteinase inhibitors has been widely performed in severe AP cases, especially those presenting hypoenhanced regions in the pancreas on CT. In 2003, CRAI was performed in 22% severe AP cases, but only in 7% in 2016. The mortality rate was not different between the patients who received CRAI and those who didn't. Along this line, a recent multi-center randomized controlled trial could not show the efficacy of CRAI in the prevention of development of pancreatic necrosis. During the course of AP, ward of necrosis 1 occasionally develops. In this study, about 7% cases developed 1. Patients who developed 1 had higher proportion of male, higher CT grade, higher number of positive prognostic factors, higher proportion of severe cases, and higher mortality than those without 1. Endoscopic treatment of 1, including endoscopic drainage of cysts and necrosectomy, are increasingly popular. In this survey, 107 patients received intervention for 1. 62 patients received transluminal endoscopic drainage, 22 received percutaneous drainage, and 14 received transpapillary drainage. Among them, 16 patients received step-up approach, including endoscopic necrosectomy. On the other hand, only 5 patients received surgery first approach. Then mortality. The pancreatitis-related mortality was 0.5% in mild AP and 6.1% in severe AP. Overall mortality of AP was 1.8%. The slide shows the trend of mortalities in AP patients. In the 2011 survey, the mortality in severe AP patients was increased from 8% to 10.1%, probably due to the revision of severity criteria, which could pick up more severe cases in 2008. Compared to the 2011 survey, the mortality in severe AP was decreased by 40% from 10.1% to 6.1%. If stratified by the reason for severity, the mortality was 9% in patients fulfilling the prognostic factor criteria only, 2.1% in patients fulfilling the CT grade only, and 19.1% in patients fulfilling both criteria. Patients who fulfilled the prognostic factor score had higher mortality than those fulfilling CT grade only. As shown in the left panel, the mortality rate increased according to prognostic factor scores. The mortality rate of the patient whose prognostic factor scores were below 2 was 0.7%, while mortality of the patient whose scores were 3 or more was 12.5%. The mortality rate was as high as 31% in patients whose prognostic factor scores were 6 or more. As shown in the right panel, ROC curve analysis showed that the area under the curve for predicting mortality was 0.86 with a sensitivity of 0.63 and a specificity of 0.92. These results suggest the utility of prognostic factor scores to predict mortality. Acute pancreatitis-related deaths can be classified according to the disease duration. The mortality rate in the early phase, that is the mortality rate in the early phase was decreased from 6.6% in 2011 to 2.7% in 2016. However, the mortality rate in the later phase after 2 weeks was unchanged, 3.5% in 2011 and 3.4% in 2016. Indeed, among the 107 patients who received intervention for 1, usually after 2 weeks, nearly 10% patients died. These results suggest the importance of better management in the later phase to further improve the prognosis of AP patients. In conclusion, we clarify the current status of AP in Japan, including the reduction of mortality in severe cases, shift to endoscopic approaches for ward of necrosis, and poor compliance of the recommendations in the guidelines, including management of enteral nutrition and antibiotics administration. Improved management of late complications, along with further compliance with the guidelines, is essential for further mortality reduction in patients with acute pancreatitis. Thank you for your kind attention.
Thank you very much, Professor Atsushi Masamune. Since he is not here, we are not going to have any questions. With this, we will like to end this session. I'd like to thank APA and Professor Saluja for giving us this opportunity to moderate this session, along with my co-chair, Professor Ida Habjian. Ida, do you have anything to add to this session?
Thank you, Pramod. I don't have anything to add.
Thank you very much.